Good morning, good afternoon, everyone. Welcome to the last day of the Mind Week Symposium 2025. Thank you all for joining, and thank you for joining this whole week. It's been an exciting week, and we're excited about the talks today. So unfortunately, today we'll only have one talk. Dr. Jaya Chanda had an emergency and is not able to join us today, but we'll definitely reschedule her talk for a different time. So today's talk will be presented by Dr. Brett Collette. And it's my pleasure to introduce Dr. Collette, who's a clinical psychologist and associate professor of pediatrics at the University of Washington and a principal investigator at the Seattle Children's Research Institute. He has over 20 years of clinical and research experience focusing primarily on neurodevelopment and caregiver-focused interventions to promote healthy development in young children. Dr. Collette has led the selection of neurodevelopmental assessments and has really supported training and capacity building for neurodevelopmental assessors in Kenya through his research work in Kenya. And it's really my great pleasure and honor to introduce Dr. Collette to this session. So as a reminder, please keep your questions, put your questions in the chat box, and we'll be sure to respond to them as we go along. Thank you. Welcome, Dr. Collette.
Thank you so much, Irene. I appreciate that. I will get my slides shared with you all. Does that show okay?
Yes, it does. Yes.
Great. Thanks, Irene. Well, it's a real pleasure to be here talking with all of you this morning. And as Irene said, I'll be focusing mostly on interventions to improve child neurodevelopment. And I'll look forward to Jaya's rescheduled talk because I am also really interested, and I think this pairs really nicely with some of the ideas around assessment that I think she might have been talking about. In terms of my goals for this morning, so I wanted to talk just a little bit about the rationale and some common targets for neurodevelopmental interventions. And then I'll give just a few examples. There are many, many examples out there, but I'll give just a few examples that are based on the nurturing care framework from the World Health Organization. And I'll talk about a couple of meta-analyses that have looked at this body of literature overall. And then where I'm hoping that we can spend most of our time and ideally have some discussion would be around some gaps and opportunities for future research. I don't have any disclosures for you, and I have just one video that I'm hoping to share, and that's shared with permission from the family. I don't suppose that for this group I really need this slide, but I do think it's always worth sort of reminding ourselves that biologically, prenatal and early childhood, this period is meaningful for intervention for lots of reasons. The brain is developing rapidly, starting in utero, and then that brain development continues quite rapidly through the first 2 to 3 years of life, and then we now know even beyond that. There are lots of things that are still developing into early adulthood. But if you look at this curve, you see that there are these times where different systems are developing in this experience-dependent kind of way. So really, they develop only if they get the minimum experience needed. And this is things like vision and hearing, language, and then higher cognitive functions like executive function and some other things that might show up on cognitive measures. So it's a really, really good time biologically to intervene. The brain is most malleable. It's some of these things are being formed day by day during this period. So as a result, this is really where the bulk of the intervention attention has gone. And then just from sort of a nuts and bolts return on investment and economic kind of a perspective, this is when we have the best return on investment. This curve is from James Heckman, who's a well-known economist here in the US. And he has shown through multiple studies that you get the most return on your investment for interventions that start during the first 1,000 days and potentially into the next 1,000 days. Just that's showing up in the literature a little bit more. But basically from that period from prenatal through age 5 is when interventions have their biggest return. And this makes sense, right? Because biologically the brain is developing, so it's an especially fertile time for intervention for that reason. And the earlier you can intervene, the longer you have to sort of get the rewards from that intervention. There are lots and lots of different targets for intervention, meaning the sort of skills or the areas that we would be trying to affect change. And one of the things that I wanted to sort of highlight here is that it would be pretty hard to intervene on just one of those. So if you look at the child bubble there to the left, for example, even if you're doing a motor skills intervention, so you're doing something based on gross motor skills like crawling and walking and sitting up and rolling over and all of those things, we know that those do affect other domains. So motor skills and language, for example, are relatively closely aligned. The motor skills predict language development surprisingly well. Motor skills predict cognition. So especially fine motor skills like picking up small toys and manipulating objects and things like that correlates pretty well with measures of cognition. And then on the caregiver side, you can imagine that if you're intervening on one domain, like a caregiver's knowledge or their use of responsive caregiving skills or cognitive stimulation skills, that's going to influence other things in the system. So that's going to be influenced by their mental health. It's going to reciprocally influence mental health. It's going to have this nice back and forth effect on multiple different areas. And then some things, of course, are overlapping. So something like attachment. In the attachment world, people really don't think about sort of a separate child and a separate caregiver. They really think about the relationship and that attachment between the two. And so you can imagine that as being this little overlapping area that we know for sure has multiple associations with both caregiver domains and child domains. So even as we're thinking about it, and it's always important when people develop intervention studies to think very narrowly about kind of what is their target. The reality is it's probably more broad than that it's probably also affecting other systems. This group would know this nurturing care framework well, I'm sure. And this outlined different components of nurturing care and sort of helped to organize things like interventions and assessments to focus on different domains that we know are especially important for brain development and for long-term health. And so increasingly when people are developing intervention programs, they're referencing this more explicitly and sort of talking about, which of these areas are they really focused on, and trying to organize their work in that way. There was this really nice meta-analysis by Ahun et al. I hope I'm pronouncing her name correctly, but from 2024, where they reviewed studies that fit somewhere in this framework. And they went back a long way. So they went back to 1974, and I think their newest studies were in 2022 at the time. They identified 123 studies that met their criteria. And most common were studies focusing on early learning. So opportunities for early learning, 78%. Responsive caregiving was around 51%. And as you might guess, there was overlap between these two. So there were many studies that said that they were addressing both early learning and responsive caregiving. And then nutrition was kind of the third most common in those studies. And again, that was often paired with one of these others. Not surprisingly, most of the participants were moms. So 96% of the participants in these 123 studies were mothers. And then in 38% of the studies, they included other caregivers, mostly fathers, but there were also a few that invited grandparents to participate, for example, and other adult caregivers for the child. By far, the bulk of the data is on interventions focusing on mothers. And when other caregivers are involved, it's often a, a bit of an aside, I would say. So it's often the case that fathers are invited to participate, but outcomes may not be collected for the fathers, or it sort of might not be the expectation that they would be participating in most of the components. There are exceptions to that, but by and large, that's the way that this has worked. One of the things that came out of this meta-analysis was they looked to see how many of the studies listed a theory of change. So best case scenario when you're developing an intervention would be that you would have some guiding principle, some sort of overall theory of change that you would say that you're working within. So you might be addressing the nurturing care framework, but then within that you would want some theory or some ideas about how your intervention is going to affect behavioral change. About 50% of the studies in the meta-analysis listed a theory of change. So many did not, and in some cases it was a little too vague to classify. But about 50% listed a theory of change, and the most common among those was social learning theory. I thought it might be worth just pausing because I think sometimes we use some of these terms without necessarily thinking about what that means. So you've probably heard of social learning theory, but it takes a little bit of a reminder to think about what that means and how that might be relevant to neurodevelopmental interventions. So as a reminder, this goes back to Albert Bandura, who was a pretty well-known psychologist working in the 1970s and 1980s. He expanded earlier behavioral theories. So earlier behavioral theories were very, very focused on reinforcement and punishment. And kind of nothing else mattered to those folks. It was all reinforcement and punishment. And what he brought about was that we have these other ways of learning and these other things that probably matter. So we can learn observationally. We can learn by just watching somebody else go through a procedure or a task or something like that. Even if we don't directly experience any sort of reinforcement or punishment or payoff for the thing, we learn by watching others. And as a result, modeling is important. So the idea that if you're going to teach somebody something, you can do that by showing them. You can do the thing yourself, and they can learn just from that modeling. Reinforcements and punishments still matter, so that's still kind of the behavioral theory. And sort of a related idea is around vicarious reinforcement. So this idea that there's something kind of reinforcing about watching somebody else succeed, and you sort of learn, oh, that's a rewarding thing to do. So you might get to another child on the playground might watch another kid on the swing, and they say, oh, they laid down on their belly on the swing and they did this kind of different thing that I hadn't thought about before, and that looks pretty fun. And there's something kind of vicariously reinforcing about that. And then the other piece here was around cognitive factors. So Bandura pointed out that what we attend to matters a lot. So there's always a lot going on around us, and some of it we notice and some of it we don't. And then other cognitive factors like what matters to us. So we don't learn from everything that's happening around us. There are some things that we attend to and that really matter. We sort of value some examples in the environment over others. So like the child on the swing set example, like a child who is especially popular, or a child who is especially well liked in their classroom, they might carry extra influence. So if they're doing an interesting thing on the swing, that might matter more than it does if it's a child who is not as well liked. In terms of bringing this back to neurodevelopmental intervention, so when somebody says that they're using this as their theory of change, you're going to expect that this will be built in, that the way that they deliver the intervention might include observational learning and modeling. And it might sort of attend to some of those cognitive factors that we think matter. So if you were going to show a video, for example, that shows a parent demonstrating a skill, you would want that to be a parent that others are going to attend to, that maybe is going to look similar to them, or that's going to look to them to be a worthy sort of role model, and they're likely to learn from. So that's the big idea, is that somehow these things ought to be, if somebody's saying that this is their theory of change, that ought to be sort of built in terms of the way that the intervention is delivered, or the things that you're trying to convey to a parent. So you might, for example, be conveying to a parent, how do you really provide good modeling for your child if you want to show them how to do this skill? How would you model that effectively for them? And how would you make sure that you had their attention? And those sorts of things. So in terms of some examples, I'll go through just a handful, but I think it's worth sort of talking about these, and I'll give just a little bit of detail about what they did. So there's a very well-known intervention called Reach Up. This was developed by Susan Walker and has been tested in multiple different countries. In this paper, they did a meta-analysis of 18 studies. So there may be around 100 or so different studies of the Reach Up program, but they had different inclusion criteria. And this meta-analysis included 18 of them. The targets for Reach Up are things like responsive caregiving and early learning. It's a fairly adaptable program, so sometimes people add other things to that. They might add some nutrition component or some health and wellness kind of component to it, but the main targets are around responsive caregiving and early learning. The format has also been very broad, so sometimes this is delivered in a home visiting format. I believe that was the original dissemination, was that community health workers were going to people's homes. And other times it's been delivered in a group, so different caregivers coming to a center or something like that to receive the content. And it has been also broad in terms of age and enrollment. So the children enrolled have been from ages 0, I think there might have even been one, there might have been like a prenatal study in there somewhere, up to 30 months at the time of the start of the intervention. And then the durations have been from 6 months to 24 months. And the number of sessions, as you can see, has varied wildly. So from 6 to 96 sessions across different programs and different implementations. And the gist is that the intervention works well, especially for outcomes like cognition and language, where the effect sizes have been around 0.4, 0.5 for cognition, and I think around 0.3 for language, and then down to 0.05 for gross motor. So that's a skill that doesn't really seem like it's been moved by this intervention over the years. But overall, this holds up as one of the more robust interventions. I'm going to talk about long-term effects in a little bit, but this is one program that has been studied several years after delivery, with at least some evidence that that effects might continue. So it's been very influential. A lot of other programs have sort of been modeled on this one as they go out in the community. This meta-analysis is a pretty good place to start. If you were curious about learning more, you could start with this meta-analysis and then sort of dive into some of the other individual studies and see what people have done more specifically. These next couple are more recent studies. So Luoto et al. Have done this trial in Western Kenya called Msingi Bora. Their targets were responsive caregiving, early learning, nutrition, and health from the nurturing care framework. They were interested, so they tested 2 different formats. They tested a format that was only group, just having people come to a center, versus group plus home visits. So I believe it was a factorial design. So they had some people randomized to a control group, some people got the group intervention, some got the group plus some home visits. The idea around the home visits was that might be important to assess implementation, sort of be able to see our parents actually doing the things that we're talking about and what is the context like and that sort of thing. The kids were 6 to 24 months at enrollment, and the intervention took place over 8 months with 16 sessions. The effect sizes for this one, they did not, I don't believe, measure motor skills. They were focused primarily on cognition and language. And you can see a pretty robust effect for cognition at 0.52, and then less so for expressive language at 0.08, and receptive language was somewhere in the middle. They did not find any difference by format, which was counter to their hypothesis. They had assumed that the group plus home visits would do better. They also didn't find any difference with the inclusion of fathers. This was one of those studies where fathers were invited to attend. They actually did measure some outcomes for them, but it wasn't sort of expected as a part of the program. And probably as a result, attendance for fathers was a bit of a problem. The dads were not necessarily there for a large percentage of the sessions. This group is doing another study right now where they're also looking at a remote version of this intervention. I'm not really sure of the status of that, but I think it's at least a couple years in progress. And then this study is a new one. So Josh Zhang et al. Studied an intervention called Effects, and this was in Tanzania. Their targets were nutrition with or without responsive care. And what they did, there was an ongoing intervention that included nutrition, things like dietary diversity and supportive feeding and that kind of thing. And they added on to that responsive care. And they did this factorial study where they looked at nutrition alone or nutrition plus responsive care. And then they also had some variables in there about dad's involvement. It was a group format. They enrolled, it was a cluster randomized trial. They enrolled anybody who had a child less than 18 months. I think the average was around 12 months for the babies at the start. And the study took place over 12 months, including 24 sessions. They did not show benefit overall. So they did not find an overall intervention effect on child outcomes. They did show improvements for maternal and paternal caregiving outcomes. So when they measured skills and things that the parents were doing, they did see a benefit, including for both for moms and for dads. But that didn't seem to translate to an overall effect for the babies. Interestingly, they saw an effect for dads. So dads' caregiving got better, even if they were only getting the nutrition intervention, which is sort of interesting. And one of their ideas was that just having dads kind of more in the conversation and more involved in thinking about child caregiving might sort of help some skills like responsive care. They did, when they looked at their different cells, they did see that adding responsive care seemed to be a little better than nutrition alone. I think some of those outcomes were significant, even though the overall treatment effect was not. That difference between what parents, what child outcomes were like for responsive care plus nutrition were a little bit better than nutrition only. And then, super interestingly to me, they saw evidence of benefit for siblings. So they did a very clever nested study where they went to those same families who had participated in the study, and they studied mostly younger siblings. And those siblings who had been exposed to intervention were doing better than siblings whose family had not been exposed to the intervention, even though they weren't the target of the original study. So to me, this suggests, again, the parents were picking up the skills. They were most likely applying them. For whatever reason, that didn't show up with the target children, but it did have some generalization and some residual effect for other kids in the house. And then going back to meta-analyses, so these are a couple. This is a meta-analysis by Josh Zhang et al., and then the meta-analysis by Ahun et al. Most common targets in the studies in their meta-analyses, again, were early learning, responsive caregiving. Often there were multiple things targeted. I forget the percentage. Most of the studies only targeted had one target, but a relatively large number were doing multiple things at the same time. Formats included group, individual, home visits, like we've talked about, and age and enrollment for this body of literature overall has been prenatal to about 5 years. And then the duration has been from somewhere from 1 month to 60 months for the studies that they included. Effect sizes are kind of what we've talked about for these other things. So the effect sizes tend to be a little smaller for motor and social emotional outcomes at around 0.2, and then higher for things like cognition and language at around 0.3. Caregiver effect sizes, so when you're looking at the effects on parents themselves, those range from about 0.3 for observed interactions between parents and their kids, and 0.6 when you're asking about knowledge. So are they sort of understanding what's being conveyed? Some of the moderators effects tend to be better in low and middle income countries versus high income countries, and effects tend to be better for the studies that focus on responsive caregiving. Some of the things that don't matter to me are almost more interesting. So engaging fathers does seem to help a bit, but it's pretty complicated. Like I was saying, some of these studies have really not necessarily done this on purpose, in a way that sort of dads were involved and sort of expected to attend. So not surprisingly, when dads are involved, often their attendance is not that great. They're there for a relatively low percentage of the visits. And also, even though the effect is not necessarily larger on child outcomes, there have been a lot of people that have said, well, maybe dad's involvement really helps to support the mom in other ways. And I think there is some evidence that mom's outcomes might be a little better when dad is also engaged. Same kind of idea with studies that have tested bundled interventions, like nutrition and responsive care has been common. That tends to be better than nutrition-only studies. There aren't very many studies testing the opposite, kind of not surprisingly, really. Like a lot of people would think maybe it's not that ethical to withhold a basic nutrition kind of intervention or something like that. But again, it's kind of complicated. It's a little hard. And in that study by Zhang et al., one of the things that they commented on was that they felt like this bundled intervention maybe got a little muddled, like it was a little bit, there was a little too much going on, and perhaps parents didn't attend to some of the things that they were trying to work on. So that's the gist. I'm going to pivot a little bit and talk about some different elements here, but that's the gist. These interventions do work. The effects are not huge. One more slide. And one of the things that we notice is in the studies that look at them over time. So when you look at kind of follow-up of even kind of short, medium term, effects tend to go down a bit. So in this study, they were looking at outcomes over these different intervals. And you can see the effects don't necessarily decrease. The absolute estimates don't decrease that much. So, at 10 plus years, you're still looking at an overall effect of 0.25, but the variability increases a lot. And so then you see that it's kind of no longer a significant effect. Because you've got some, for example, in this long-term example, you've got the Peter Cooper study that after 12 and a half years, their effect had essentially gone away. Grantham McGregor study where their effects were retained. That was the reach-up intervention. Some people have talked about potential for sleeper effects. So this idea that maybe something different would happen long-term, that if you might not see a big effect at a short-term follow-up, but you might see that at a longer-term follow-up because there could be some benefits that only emerge as kids get older. There's not a ton of evidence for that in this literature in particular. There's a little bit of evidence from studies in the U.S. that have focused on this, but not a lot from this literature. And one of the takeaways seems to be that you're really targeting an immediate effect of greater than 0.3. If you're at that point, that seems to be kind of a cutoff where then you have a chance that your effects are going to be retained. But if your effects are not that large immediately after an intervention, there's a good chance they're going to wash out. And then there's also been just a little bit of study about sustained changes in responsive caregiving and maternal and paternal stimulation. And that's not surprising. Basically, if you have sustained changes in parenting, you're more likely to have sustained changes in child outcome. Okay, so now I'll pivot a little bit to think a little bit about gaps and opportunities. And I identified a few, and I hope that we might have time to discuss other gaps that you all see. One of the things that I'm thinking about a lot in a study that we're doing in the US right now is how to get really good measurement of the mechanisms for an intervention. So, in addition to having a theory of change, you really kind of want to know what is it that really has to happen for this thing to work. And in our study, that's a study to promote language development, this basically comes down to conversational turns, like how many back and forth conversational turns a caregiver and a child have. And basically, we feel like if we don't move that, it's not super likely that we're going to be effective, because there is this literature on conversational turns that shows that this is associated with brain development. There's the more conversational turns you have as a baby, the better development you have in language centers when you're around 5 years old, and also with language development. So more conversational turns when you're a baby, better language development when you're 5, 6 years old, something like that. So for us, this came down to a really important mechanism that we felt like we needed to figure out how to measure well. This is a proxy for a serve and return, and you guys likely know this about serve and return interactions between a parent and a child, where one partner is putting something out there, they're making a bid for attention, and then the other partner responds to that. And ideally, that response comes back smoothly, and you have this very nice little cycle. But occasionally, it gets disrupted. Like the signal is not super clear, and so you kind of go astray a little bit. And I've got a video that I'm hoping will show for us. Please, I don't know how you'll tell me, but maybe Irene, let me know in the chat if the sound doesn't work for this.
Yeah. Right there. He's so little. I missed him at first. What are the things you see?
Biggie, biggie, biggie.
That's some biggie what? What do you think it is? Is that some bones? Yeah, it is some bones.
Egg.
And an egg. Good eye.
Egg.
Another egg. You know what those are?
Carrots.
Carrots. You love to eat those, don't you?
Yes. Tomatoes.
Those are tomatoes? Do you like to eat tomatoes too? Yeah, you do.
I just smile at that example every single time. But it's a really good example of these conversational turns. You can see multiple times along the way there where one partner makes a bid for attention and then the other partner sort of responds to that. And what we are doing in our lab is we're getting counts of those conversational turns. So we would sort of count how many times there was a cycle where one partner, either on our team, we're including gestural communication. So like where Bennett, the little boy, points to the picture, we would count that as a bid or a serve, and then we would count the parent's response as a return. And fundamentally, we think this is pretty important again. So we think that this count of conversational turns matters a lot, and that it's probably the mechanism that our intervention might work through. Other studies have sometimes not been this specific with their mechanisms, or they haven't really measured them at all. And partly that's because it's super labor intensive. There's not a real easy way to do this, I don't think. And partly I think it's because it's sometimes a little hard to kind of get down to really what is the mechanism, what is the thing that we think might make this work. And one of the things I was thinking about is sort of like if we were doing a motor intervention, we were doing something to target gross motor intervention, which seems to be an area that interventions don't work well for right now. What would this look like? What would the conversational turn for a motor intervention look like? And I'm a little bit stumped, to be honest, but I'll bet that we could come up with something. But to me, this seems like a promising area. And then at the end, if your intervention doesn't work, then you kind of know, okay, we measured the mechanism, the mechanism worked, the intervention didn't work, so that something was wrong with our hypothesis there. Or the opposite, you might say, okay, we didn't do anything to increase conversational turn, so it's not surprising that the outcome was not better. So to me, this seems like one remaining gap is that we're not super good in this world about measuring the underlying mechanisms. The other gap that is sort of pointed out by that analysis of long-term effects is that we don't always plan very well for sustainability. Effects seem to wash out over time, kind of no matter what we do. And even probably it's more dramatic than that meta-analysis assumes, because the studies that don't have an immediate effect are not really represented there because they probably didn't get published to start. One thing that we were thinking about, this was a project that Irene was actually leading, that was thinking about interventions for a population of kids exposed to HIV. And we were thinking in that study about what a developmentally informed longitudinal intervention will look like. So we have these domains that we're addressing. We're going to address language and motor skills. And we tried to think sort of at each of these different points, each of these different kind of intervention points, what would be the relevant thing that we could do to move the needle on one of those outcomes. So for language, for example, if you're working with a 0 to 6 month old, probably it's not going to be book sharing quite yet, although there's never a bad time to look at books with your baby, but probably it's going to be something more like thinking about the language that you're using in the home just around the child, and maybe singing and things like that you could do, so that just the milieu for the child has a language richness to it. And then later on, as they get closer to 12 months, 13 months, then you might start thinking about book sharing, or you might start thinking about more explicit interventions to target gestural communication or that sort of thing. And then by the time they're 19 to 24 months old, you could think about storytelling. You could think about sort of not having a book that we're looking at. We're just talking in the abstract about stories, either from our family or just kind of talking about what happened during the day. And same kind of thing for motor skills. The other thing that I was thinking about here was that it may not even be best to think about this as being age dependent. And you could, for example, think about results on the MDAT or on the Bailey, some assessment that you were doing, and sort of you could use that to say, okay, so here's kind of where the child is developmentally. Their age doesn't matter that much because they might have delays, they might be advanced. And so you might use that as the basis for your intervention, and sort of have this loop or this connection between your assessment of development and the kinds of interventions that you would target. I was thinking about those booklets that I think you guys use in Kenya during visits, where parents you're talking about development, you're having this conversation, and sort of regardless where the child is on the spectrum, you might have a range of different options that you would talk about. The other way that I've thought about sustainability is just within communities. So I've thought about a lot, but I haven't done anything about it, about embedding programs within existing and trusted systems. So there's this concept around faith-placed care, where it's your intervention or your program is not necessarily religious in its content, but you're taking advantage of the fact that you've got this population of people that happen to attend church at least once or twice a week, and they trust the people around them, they trust the people in that community, and it's a good way to deliver health messaging. This is done with adults, so there have been studies in the U.S. and the Southeast U.S., and then there are these handful of studies in low and middle income countries doing this kind of thing with adults for things like cancer screening, blood pressure screening, and diabetes management. And there's really no reason we couldn't do something like this for child health and for child development. I really do think there's a lot of promise to this, especially in communities where this is a really central part of people's day-to-day life. One other gap that I've been thinking about, so most of our interventions that we test in big studies have to be very standardized, or we've at least felt like they have to be very standardized. So it's kind of like everybody gets the same components. They come into the study, you know what they're going to get. You got people trained up to do that exceptionally well. But that's not always very individualized, and it's not always a very good fit for the family's interests or their skills or the child's needs. So in the US, there's some thought about how you could individualize programs at scale. And one really nice example is this intervention called the Family Checkup that was developed mostly for behavior problems in toddlers. And the way that they conceptualized this was that they had these strength-focused assessments. Where they would do these evidence-based measures with the family. They would look for both strengths and weaknesses. So it wasn't like they were only looking for problems and looking to diagnose something. In fact, they didn't diagnose at all. They were just assessing different domains that we know are important for kids' development. And then they were giving families feedback based on that. And they used a motivational interviewing approach where they would share the feedback, they would share the objective data. But then it was really up to the families kind of what to do, if anything. Like they would sort of make the case. They might say something like, well, it looks like your child's doing great in motor development and cognition. That looks like it's kind of right where it ought to be. Language is kind of the area that is different, where your child is not saying as many words as other kids their age. And that's a thing that we could do something about. Would you want to hear some more about that? And then the gist with motivational interviewing is you really kind of have to accept the answer. So if the parent says, nope, I'm not worried about their language development. Dad was a slow talker. and brother was a slow talker, and we think it's going to be just fine. And the interventionist would have to be okay with that. And they might say something like, okay, that's completely fine. That doesn't sound like you want to do this right now, but please know that there are things that we could do to help with this if you changed your mind. And then they would offer a menu of interventions, sort of based on the child's needs, based on the family's interest. They would offer this sort of range of different things. So like that family that I'm mentioning, you might say, oh, okay, so it doesn't sound like you want to meet with somebody. Can I give you some stuff to read, or can I give you just a little bit more information that you can take with you, or no, either one's okay. And you would kind of go from there. They offered a range of about 1 to 10 sessions after each of these different assessment visits. They did longitudinal care over about 1 to 3 years, I think. I didn't actually reread all the studies to confirm that, but that was the gist, was that they might over 3 years, they might have like an annual or every 6 month kind of assessment or something like that, where they would go through the cycle, and each time they would share with the family the data and this menu of interventions. They've shown very nice effects. There are now a couple hundred studies. This has been used fairly widely in the US and a little bit in Canada. I don't know of any work outside North America, but basically this seems to work pretty well. And I like that it sort of acknowledges that intervention could be tailored a little bit to what the family actually needs, and this idea around motivational interviewing about what they're interested in doing too. Oh, this is just an example. So in that menu of options, for example, so like let's say our child with the language delay, you might have kind of a range of different things that you would offer. So you would say, well, there are lots of different things that you can do to promote language development. You can look at books with your child. You can tell stories and involve them in telling stories about what happened during your day. You can do child-directed play. You can really focus on conversational turns, and you can sort of count those in your interactions with your child and think about kind of what works best. And then you would ask sort of which of those sounds like it might be interesting to you. Is there any of those things that you guys already do, or that might be a good fit for your family? And then the family can tell you, and then you're off and running. You're focused on that thing, and you might have other options depending on kind of what other needs were. And then a child with multiple needs, you might sort of leave it to the family to think about where to start. So let's say a child has both language delay and behavior problems, which is not at all uncommon. And so then you can kind of leave it to the parent and say, well, which of these do you really want to tackle? Is there one of these that you think is getting in the way the most, or is there, what do you think? And you might even notice, oh, look, there's this child-directed play thing that kind of works for both behavior problems and language delays. So maybe that's a place to start. You might get extra benefit from that. Again, this has been used in the US. There are kind of similar programs for adolescents. There was a similar program for adolescent substance use, but I'm not aware of anything outside of North America. 2 other gaps that I thought about, and then I hope we'll have a good time for a discussion. One of the things that I've been thinking about is sort of how should we be reaching out to other caregivers, like informal caregivers or other people that day to day spend a good chunk of time with the child. I've been impressed in the studies there in Kenya that this question comes up a lot about sort of another caregiver coming to their study visit for their developmental assessment. And I know that we had conversations around this, around observing caregiver-child interactions, because there are, of course, some caregivers where mom is really an important breadwinner. She's working most of the time, so the child is with an aunt or with another caregiver who probably has a lot of influence over that child's developmental outcomes, and they're not usually included. So that meta-analysis by Ahun et al., there were other caregivers included, but again, they weren't exactly the target. It was kind of like they might be invited if they could come. But if you think about this group of caregivers, they might have fairly big influence from a public health perspective, because they are likely taking care of multiple children. And so in terms of providing cognitive stimulation, you might have a lot of benefit by targeting those informal caregivers, getting them really trained up to provide responsive care, educational opportunities in the home. To me, one of the questions here would be like, how do you do that without alienating the parent? To me, there's something sort of fundamental about wanting mom or dad to be primary, but it also does feel to me like there's some potential benefit there for including other caregivers that are common. Yeah, and then one of the things that I've been thinking about a lot that came up in that study by Luoto et al. Fairly recently. So when people, researchers especially, think about fidelity and adherence to an intervention, often it comes down to pretty basic checklists. And did people come or did they not come? And did the interventionists do the 5 different things we asked them to do, or did they not do that? And we know that this other things matter. So the quality of intervention, of course, varies among different people. And things kind of a lot like caregiving, to be honest with you, like things like their responsiveness and their warmth and their perceived expertise, and are they organized? These things matter a lot. And there are studies that show this, that basically, in addition to fidelity, sort of better quality of intervention matters and increases engagement and produces better effects. In our study that we're doing here in the US, we're using this tool there in the table where we observe the intervention sessions. We recorded, I think, 10% of them, and we code them. And these are the kinds of things we look at. We sort of want to see, are people conceptually accurate to the model? Are they going off doing their own thing? Are they responsive and observant about parents' needs? Are they structuring the session? We've got we've trained some folks who are just super warm, super delightful, and super disorganized. And I'm one of them, to be honest with you. But you can see it, like when they're delivering the intervention, it's kind of like, well, they're all over the place, and that could be a little hard to follow, even though they seem really nice and the people want to follow them. And then sort of related to that, careful and appropriate teaching. And then for us, visuals are important. And fundamentally for us, it's really important that when we're meeting with parents, we're inspiring some hope and some growth fostering. So we're thinking about this as like a developmental thing for everybody. So, here's where we are today, but we really think there's good potential for growth, and doing some of the things that we're talking about in our intervention are important for that. Luoto et al. Did a really nice version of this. They had a different set of things that they coded, but the gist was kind of the same. And overall, this is pretty rare, again, because it's expensive, it's time consuming, and it's hard to pull off in big studies. But to me, there's something very fundamental about this that we need to understand when we're thinking about whether interventions work or if they don't work. And just a couple of last thoughts. So there's lots of good reasons for me and people like me to be humble. There's a book that's now kind of dated. It's from 2003. It's called Raising America, and it was a history of parenting advice in the US in particular. This really kind of took off in like the late 1800s, early 1900s. There was this big movement around parenting and parenting experts and things like that. And the author has this really compelling scene. I think it was in Baltimore, but this expert was there speaking. This group of moms were coming to attend. It was almost entirely moms, and they were mostly very well-off moms. And the points that the author makes is that at that time, the experts were all men who probably had not been very involved in caregiving. They probably had some book knowledge, but they had not been involved in caregiving to that point, really. And the moms who could afford to come to this thing were probably not that involved directly in caregiving, because they mostly would have had helpers at home who would have been doing the day-to-day care for their babies. And some of the advice was just dramatically bad, like, talking about the importance of not holding your baby very much because you might spoil them. So you really needed them to be in their crib on their own more often. And, just a series of things that we know don't make sense. And one of the things that I'm constantly thinking is, I'm just as vulnerable. There's a handful of things that I really think probably work that I'm probably wrong about. And I think there's really good reasons to continue to be humble and to be curious about sort of how these things work. So that's one reason for humility. The other reason is that most of our developmental research is with Western, educated, industrialized, rich, democratic populations. And this is really these images there at the bottom are from these pretty basic developmental psychology kind of studies. But basically around 95% of the participants in these studies, all of the published studies, are from North America, and the vast majority are English speaking. And that's getting better. I believe there's now really good work happening in all kinds of different places around the world, and it's being published more often and recognized and things like this. But still, some of the fundamental things that we know are really based on a very narrow slice of the population, and it doesn't mean that it's not right, but there's good reason to just be, again, curious and humble about whether those things are going to generalize well when we think about them in other settings. That's kind of what I have. I hope I hope that we have a little bit of time for discussion, and I'm again really curious to hear other people's thoughts about gaps and things in this literature that I am probably missing. So thank you.
Thank you so much, Dr. Colette. And we do have time. We have 34 minutes. that's pretty good time for discussion and questions. Maybe we can start with the ones in the question and answer section. I don't know if you can see them, Brent. We have 3 questions there. We can start with those, and then we have some more discussion. You're on mute, Brent.
Thank you. Yeah, I hadn't seen them, but I do now. That's great. So the first question for the study in Tanzania, can it be argued that the target kids were too young for the assessment tool to pick up the positive impact that was noted in older siblings? Yeah, it's definitely possible, and one of the things that this is making me think about is the measurement. I believe their outcome measure was the Bailey, and their kids were mostly enrolled around 12 months. So you could argue this that some of the things that you'd expect impacts on, like cognition and language in particular, they might have just not seen effects for. The siblings, the separate study with the siblings were usually younger. I think they included older siblings as well, but most of the siblings were actually younger. And I think at the time of assessment, they were younger as well. So that wouldn't quite explain that discrepancy. One of the things that sort of comes to mind just thinking about this is that I wonder if their assessment of outcomes was almost too soon. Like the parents needed more time to practice some of the things that they were doing and implement those at home. And so they weren't picking those up for the target kids, but they did pick them up for some of the other kids in the home. So that seems possible, but I think it's a good question. The next question here was about sleeper effects in the Stanford marshmallow experiment on delayed gratification. Yeah, and the person is asking, so it's not a direct equivalent, but wouldn't you agree that a follow-up with the subjects later in life might manifest a positive impact? For anyone who might not know it, so the Stanford marshmallow experiment was this well-known test where the experimenters had kids come into the lab. They gave them a marshmallow, and they said, you can eat the marshmallow now, or if you can wait, when I come back, I'll bring you a second marshmallow. And the experimenter steps out of the room. And some kids, of course, eat the marshmallow right away, and some kids do not. Some kids wait for that second marshmallow so they can double their marshmallow reward. And this has been associated with lots and lots of very long-term outcomes. So economic outcomes, health outcomes, other behavioral outcomes. It's a remarkably robust task. And you're absolutely right to think of that as an example, like, this thing that they observed when kids were preschool age, maybe around 5, had these very long-term benefits. And for sure, I think that's possible in lots of these studies where they might not see a big benefit right off, they might see something later. I guess that some of those, I would say some of the studies where they've looked at this, though, that hasn't borne out as well. I mean, if you think about some of those long-term studies, like that study by Cooper et al., where they looked at the kids 12 years later and they were not measuring effect, even though they had right after the intervention, I would have expected a little bit of something to happen there. But but I like to think that it's a possibility. And in Heckman's studies, in the US, there are some of those where he's found this kind of thing, like kids get the intervention when they're preschool age, and then when they're adults, they're more likely to be able to keep a job, they have better income, better educational attainment. This next question from Nathan says, could you shed some light on the role impact of gadgets? We see kids, 2-year-olds, as experts on video games, apps, and all that. At what age should these be introduced, if at all? Do they stifle neurodevelopment? I love this question. And the short answer is yes, they do stifle development. That's shown. There are studies looking at language development, for example, and language development is negatively affected by how much time kids spend on screens. Attention, there are studies about associations with attention problems when kids get older and early screen exposure. So for sure, yes. And it's a thing that we wrestle with in our study. So we're, in our study in the US, we're focused on book sharing. And it is a place where gadgets for sure get in the way. So we have, as a component of our intervention, we say that before you start reading, you would really want the phone somewhere else, and you don't want to be reading to your kid in front of a TV because you just can't compete. Those video games and apps and all of that are built to keep our attention and to hold our attention, and despite other things going on around us. And the thought with the language development is that they really do get in the way. So they push out other activities that can promote language. One question that comes up for us has been around, people will look at books, they'll have a tablet and they'll look at books with their child on there, or they'll look at an app that's intended for language development or for literacy. And they want to know whether that's okay or that's a good thing to do. And mostly we say no, to be honest. Like, there's pretty good evidence that the way that people look at books on a screen, even if it's a tablet like a Kindle or something like that, that's intended for reading, the way that parents and kids look at those together is different than looking at a printed book, and it doesn't tend to draw some of the same qualities that are needed for language development. Let's see, the next question is, do the studies in the recruitment try to identify the primary caregiver, or is it mostly assumed to be the parent? That's a good question. I would have to look at the details for some of these studies, but I assume that it mostly has to be the parents because they're needing to get consent for participation. And that would usually not be possible if it wasn't a parent or a legal guardian. The other thing that this makes me think about is, like, in some of these other studies, have they said a primary caregiver has to participate? It can be mom or dad or other, but it has to be kind of a legal guardian who can provide consent. That is what we do in our study in the US. That is how we do it. I think in our sample so far, about 85% are moms. Maybe 14% are dads, and 1% are other, like a grandparent or something like that. But I think the population that we miss are some of these informal caregivers, somebody in the neighborhood or an aunt or somebody like that who's not the legal guardian. They haven't taken over care of the child, but day to day, they're the ones spending the time with the child, and potentially a really helpful person to work with for an intervention.
Yeah, thanks, Brent. And just to follow up on that response, I think that's a very relevant question for a setting where there's a lot of help in the home, so house helps who really spend the bulk of the time with the children, and we usually typically do not include them. In the talk on Wednesday when we had a discussion about hearing, I think this is something that also came up very strongly, that whoever is in the house should be included in supporting the child to gain hearing, particularly for the children who just got hearing aids. So I think that's something that we definitely need to explore. It's different from how it is in for example, in the US, where usually it's a parent or somebody else, or it's a daycare place. But in Kenya, it's usually house helps who are hired to take care of the child within the home. So I think we can think about that in our future studies. Maybe as we wait for more questions, I wanted you to talk a little bit about book sharing and what is it about book sharing? Because again, book sharing may not necessarily be something that, our populations might necessarily be able to do or want to do. Is it really about the pictures in the book, or is it really about a conversation starter so that you can have something to talk about with the child?
Yeah. Well, of course, you're asking about something that I'm super passionate about, as you know, Irene. So I could talk for a really long time about this, and my whole talk could have been about this, but I tried to restrain myself. So when we think about book sharing, actually the ideal books for young kids don't have any words at all. And that is because both they're accessible to a wide range in parent literacy. Nobody's going to be intimidated by this book that doesn't have words that they might not be able to pronounce or something like this. And even if they're quite literate, sometimes that's a distraction for parents because they feel like, oh, I have to read all of the words sort of front to back. That's kind of the task when I'm looking at a book. And in dialogic book sharing, that is actually not the task at all. What you want during dialogic book sharing is a back and forth interaction with the child. So you want them to be looking at the pictures and pointing to something and having a conversation with that thing that they're interested in. That's why it works, is because you're really following the child's lead. And that is so much more effective in promoting development than getting the kid interested in what I want to look at. So yes, absolutely. The book is mostly a tool. It's mostly a venue for promoting conversations and getting some of those conversational turns started. And it is unique, so that there are other ways that you could do this, and I'm actually super interested in studies that might test different ways to promote conversational turns, and to really put some research to that and sort of say, is dialogic book sharing really better for that than this other thing, which might be storytelling or singing, or lots of other options come to mind. And we don't have good examples of that. But there's good theoretical reasons to think that book sharing is important, because it does have this connection with a visual stimulus that's right there in front of us that draws joint attention, draws gestural communication like pointing, and then also promotes language.
Thanks, Frank. And do you know like how many books, like if you use the same book all the time, do the children at some point get tired of it, and do you have to have variety?
Yeah, that's a great question. What I hear mostly from parents is is kind of the opposite, that it's the parents that get tired of looking at the same book, and not the child. I mean, best case scenario, you might have a few around because they might just prompt different language. So if you're looking at the same pictures, the same thing all the time, you're probably going to have the same kind of conversations. But if you have a few different books, that might prompt different conversations.
Thank you. We do have some more questions in the chat box, so we can tackle those.
Yeah.
And,
so this first one, in church we have Sunday schools. They involve a spectrum of age groups clustered together. What effects does this interaction have on individual child development, considering they are at different age sets learning the same subject simultaneously? Oh, I love this question. So that actually is probably a very good thing. There's this whole developmental school of thought that was promoted by Vygotsky, this Russian developmental guy. And he thought very strongly that different ages was important. So kids having exposure to peers who were just a little bit older than them was especially important, kind of for both sides, because the child who's a little bit younger is kind of learning and observing and modeling what the older child is doing, and they tend to value them very highly because they're respected. They're a little bit older. They're doing interesting things, and so it was very good for learning from that perspective. And often the slightly older peers are good at sort of helping with scaffolding. They're good at helping think about kind of what's the next thing that you might be doing. So if you're if you're a toddler on the playground, you know, you're just kind of toddling around, picking up things and picking up rocks and that kind of thing. But you see a slightly older child who then is like crawling on the swing and they're doing this other super interesting thing that's not so far out of your ability. It's like it's something that's within your grasp. Uh, and then for the older child, there's something very important about perspective taking and thinking about, oh, what was it like when I was a little bit younger, and you know, what would this little person need? So to me, it's a long-winded way of saying I think it's actually a really good thing that you have mixed age groups. There are different school programs, like Montessori schools are intentionally developed this way so that kids have access to kind of a range in age. And I think it's a lovely thing about Sunday schools. The challenge, of course, is like keeping them all wrangled together and sort of keeping the 5-year-old interested and the 2-year-old from eating rocks or doing something, you know, doing whatever they're going to do. So that's hard for the Sunday school teacher. But in terms of the development and the learning, I think it's a beautiful thing. And then the next question says, I was concerned that we might be targeting the wrong people with the interventions and probably then diluting the effect we could be seeing. Oh, okay. And this must be about other caregivers, informal caregivers, and other caregivers in the house.
Yeah, I think a big gap that we need to think about.
Yeah, and this is pretty novel as far as I know. I don't know of other studies that have really done much with this, and I agree. I think it's a really promising area for research that, again, kind of from a public health perspective, I'm guessing might have pretty broad reach, because you might those people who are taking care of kids in one household might be taking care of kids in other households too, and might be having their own children at some point, and so there's a lot of potential payoff there.
Mm-hmm.
The trick, to me, one of the tricks to me, is how do you do that well without either alienating the parents or having the parents feel like they're left out of this thing that I think is very central for their kid. And I picture that being a little tricky, but manageable.
Yeah. So Brent, if we step back and think about, you know, your initial, how you started this talk, you know, and talked about the nurturing care framework and all the components of the nurturing care framework, but then you also talked about how, you know, studies kind of focus more on specific aspects of the nurturing care framework without looking at it as a whole. Mm-hmm. How do you think about how we can, you know, use the whole nurturing care framework in, you know, to really improve child development in a package, in an intervention package that helps us really disentangle the effects of, you know, each of them, because this would definitely be a combined intervention. How can we do that well?
We should fund your study. You know, that study that you had in the U19, that was such a lovely attempt at this. I thought I really I think that's about as good as anything that I've seen. It's hard because it takes huge samples. So what funders are, we just had a conversation with a foundation about a grant related to this, and the thing that holds them back is they feel like, well, how are you ever going to know which components were critical? You're going to have a ginormous sample with a bazillion families in it, or and at least the perspective of this funder was that or it's not that meaningful, or it's just going to be all kind of muddled. I don't know that that's really right, but I do think it's probably true that you got to have a big old sample. So that's a problem. I mean, I suppose just thinking out loud, I don't have a good answer, but I'll keep talking anyway. So you could at least measure these things. You could at least propose to measure these things well, so that you would say, well, we're going to intervene in these little corners of the nurturing care framework, and there's other systems of care that are already doing this thing, or we can sort of measure variation in that thing. So like safety and security, for example, if you were to think about an intervention, maybe a cluster randomized intervention, and you knew that one cluster was safer than another cluster, you might take advantage of that kind of natural experiment where you would say, well, we're going to measure these things really well, exposure to violence or whatever the threats are. And we're going to try to understand that variability a little better. We might not be able to do a lot about it, but we're going to understand that variability better.
Okay, thank you, Brent. We have one more question in the chat, in the Q&A.
Yeah, so the question is there a difference in development between children who are firstborns compared to those who have
And
siblings?
I welcome questions from other panelists.
Yeah. Birth order does matter. And I wish I could cite you the exact study, and please fact check me because I could be wrong. But my recollection is that kids who have older siblings tend to develop language a little bit quicker. You always hear exceptions to that, and there are some people that say, well, their older sibling just talked for them, so they were a little bit slow to talk. But I think on average, having siblings is positive for language development. My memory is that having an older sibling helps with language development, but again, I'm a little sketchy on that.
Thanks, Brent. This is really great. It's Dalton. I just wonder and this you've touched on this, that the books are better than the gadgets. It's a huge problem because people who would be looked at as leaders in the community, moved towards these gadgets. So maybe thoughts on how you've been or others have been able to deal with this issue, just to convince someone that just looking at a book actually is better than looking at the latest electronic or digital gadget that you use with your child. I think that's a really big problem. Thank you.
Yeah, it's good to hear you, Dalton. I agree with you completely. And I don't know of really good examples where people have solved this, to be honest. Yeah, I don't have a good reference for you. I do know that sort of in our study, at least, we address the knowledge component of this, because I think there are many really well-meaning parents who just feel like, oh, my kid really enjoys this thing. They enjoy looking at this thing, and they're saying letter names, and it seems like it must be about reading and language, and so I think there is an educational component to that, and we offer that, saying, nope, that actually doesn't help with your child's language development. And it takes the place of this other thing that really does help with child language development. So there's that. And I think certainly as pediatricians, you guys are in a wonderful place to have conversations with families routinely where they're thinking about this. They're probably asking questions, or at least your interactions with them can be a touch point where you can sort of drive home this message that really just playing is so much better than any device that we could offer. So that's part of it. And then I think the other part of it too is that for adults, we would really have to question our own use. So, again, think about social learning theory. So even if you're a parent who is not giving their kid a gadget all the time, if you're looking at your own gadget all the time, you're doing a lot of very potent modeling, and your child is learning a lot about that thing. So it's likely to be very highly valued and very interesting to them.
Brent, I appreciate that you brought in the theories on, from Bandura, and thinking about self-efficacy.
Mm-hmm.
And just, it made me think about, early experiences with responsive caregiving. And then that made me think about, we have a questionnaire about adverse childhood experiences, which is used a lot, has a lot of evidence around it, but I don't know of a similar questionnaire that would go to the opposite side and just ask about experience of responsive caregiving. And I wonder if you've ever thought about that.
Yeah, that's interesting, Sarah. Not a lot, to be super honest. I haven't thought about that in a very systematic way. But when I take that back a little bit. So one example of how we do this in our study here in the U.S. is where we're talking about book sharing. we have at the outset a series of questions for parents about what they remember about looking at books with their own family, and what they remember about, looking at books when they were a child. Did they like to read? Were they read to? So it's very proximal. It's very specific to the intervention that we're doing. But I love those conversations. Actually, it's one of my favorite parts of those interactions with families, because it usually is kind of an interesting little conversation starter. Like, people will say, "Oh, my parents didn't read to me much, but my brother did. My big brother was like just a little bit older, and they read to me all the time." Or they'll say, "Oh, definitely, I remember my mom reading, whatever the book was that stands out." People usually have things to say. And that does kind of get a little bit, I think, at what you're talking about. And I think it's a worthwhile conversation virtually always to sort of think about, how does this relate to something longer term for you that you remember as a kid? Do you remember, times where you and your mom or your dad would have conversations, and how did they tell stories with you? Like, did they involve you, or, thinking about those kinds of things? So it's not exactly getting at efficacy, but it does seem like it taps into something that's important.
Yeah, thank you. I love that response. And I also thought a little bit about during your talk, just when you were talking about the sort of the booster interventions
Yeah.
to improve longevity of the efficacy outcomes, I thought, I wonder if there would be something to pairing those boosters with a conversation, if you will, about efficacy, and just a supportive conversation about, like, to reinforce the idea that a parent is so valuable in their child's life and is doing their best and is doing a wonderful job, and that kind of a conversation as being an important part of the booster,
Yeah.
as well as the kind of cognitive part where you're just trying to reinforce certain activities.
Yeah.
And
Yeah.
then I wonder which one is better or more important.
Yep. Yeah, I think that's a really good point, Sarah. And one of the things that we have thought about, kind of related to that, is a growth mindset. So there's a body of literature about how people respond when things don't go well, or when they've failed at something. And a growth mindset would be about, sort of leaning into it and sort of taking it on as a challenge. And how can you continue to work at this thing? And that's kind of what we think about with parents is, you're going to try some things. Like, when you're first trying dialogic reading, it's probably not going to go that well, honestly, because it's probably going to, it's going to be a little funny, and it's going to be a little awkward. Maybe your kids are just going to want to chew on the book, or, something. But growth mindset would be all about sort of leaning into that and sort of thinking, oh, okay, well, so you're not quite there yet, but here's the kind of next steps. And to me, that's very efficacy building. Like, that's very much where efficacy comes from, is that you have a few things like that. You have some challenges, and you conquer them. You overcome them in some kind of way. So I like that. And I do think I'm totally guilty of sort of getting so focused on the skill, as if it's the skill that matters, like the specific thing that we're trying to teach them. And probably it's not. Probably it's more the process and the attempting the skill than actually how it goes.
Thanks, Brent. We do have some maybe these last two questions in the Q&A, and then we can wrap up.
Okay. So the first one from Precious: would change in the family culture and structure add value in replacing screen time by modeling? For toddlers, probably engage in gross motor activities and fine motor activities, introduce reading culture with the family, etc. Yeah, for sure, yes. So anytime you're thinking about a behavior that you want to decrease, you want to think about what the replacement is going to be. It's kind of a behavioral principle that if you're going to get rid of a thing, you got to have something that's going to fill that same function or meet that same need. So for sure, that's relevant to decreasing screen time, as you would think about what's going to replace that. What's going to, what else do we have that could be options there? it's hard with screen time because, again, those apps are built to keep our attention for really long periods of time. And some of them are even adaptive. So they detect if you're losing attention and then they change them. And that's pretty hard to compete with. But for sure, for parents, like if you were thinking about, okay, when does your child use a device? When are they on that? And what function is that serving? And is there something else we could do instead? So like if a mom is saying, well, my kid looks at a device when I'm making dinner because like I need them not in the kitchen. I need them out of my way. I need to be able to do this thing. Then you would think about, okay, so what else could serve that role? What else could do that for you? I think that's what you're getting at with the question. Let's see. Another question: does music have significant lasting cognitive effects on under 1-year-olds? That's a super interesting question. I don't know that literature, to be honest. It's my understanding that it does. I suspect what would matter there is not so much the exposure to the music as the exposure to the person. Like, singing songs with a caregiver, I think is very likely to have a lasting cognitive effect and to be good for brain development. Just the exposure to the music, I'm more skeptical about, but I don't know that for sure. And then the last question here from Francis: did you consider language development in relation to children with disorders like autism? Would that affect the development? For sure, yes. And we in our interventions have been thinking not so much about kids with formal diagnoses of autism, but about a very broad range in communication. So for our studies, we think about all the way from gestural communication, where it might just involve pointing to something or responding to a point, to full-on language using combined speech, where you're linking words together and asking questions and things like that. And kids with something like autism might have impairments in multiple of those areas. Even things like gesture might be a problem, but we do think that that's at least a starting place, would be to think about really broadly what would you want? What would accommodate the kid who has very little joint attention, very little language, all the way up to the kid who's a rock star and speaking in full-on sentences. So I hope that helps. Oh, last question. Brenda got in with one last question. How early can autism be detected, and what would be the signs? That's a complicated topic, and I don't have time to do it justice, other than to say that there have been studies about detecting signs of autism in kids around 12 months old, and usually it's thought that a diagnosis can be made by the time a kid is 24 months old with good reliability. And you would be thinking about things like eye contact. Are they looking at their caregiver? Are they pointing to things? Are they following a caregiver's point? Some of those kinds of things tend to be the earlier signs.
Thank you so much, Brent. We ended up using all the time, so it's really good and such a nice discussion. And you can see the interest in this.
Yeah, great. Well, me too. I share that interest, of course. So I appreciate it.
Field. So I think some key things, impacting development, maybe build some evidence, figure out how to work with caregivers. Oh, sorry, can you hear me? Mm-hmm. Okay, yeah, and then think about other caregivers in the whole.
Great. Yep.
Home. So that concludes our session. So for another Mind Week Symposium, hopefully in the next 6 months or maybe next year.
Great. Thank you, everyone.